Good afternoon, one and all present here, respected teachers and my dear friends. I am Ayush, and these are my friends Abhinav Kumar Das, Aditi Manji, Abdul Rahman, and Abidul Rahman. And our topic is lipoprotein metabolism. So, before we dive into metabolism, first we have to understand what is lipoprotein itself so that we can understand its metabolism. So, as we know that as the fat hydrolyze and break down, lipids are generated. These lipids can't be transported as such in its original form in body. So, to enable their transportation, proteins get attached to its periphery so that they can be transported. So, lipoprotein Lipoprotein are a large water-soluble macromolecules complex formed by the combination of lipids and proteins. And major function of the lipoprotein is transportation of the triacylglycerols, phospholipids, and cholesterol. So now let's talk about the structure. So the structure of the lipoprotein is mainly consists of two parts: the hydrophobic core and hydrophilic periphery. So hydrophobic core is composed of cholesterol esters and triacylglycerols and non-polar tail of phospholipids. And the periphery consists of the polar head of phospholipids and free cholesterols and amphipathic group apolipoprotein. So what is apolipoprotein? Apolipoprotein is nothing but a protein part of lipoprotein. So here is the structure of lipoprotein. This is a hydrophobic core, as a triacylglycerols, the cholesterol esters, and you can see the polar head, polar tail, non-polar tail of phospholipids present here. And these are the periphery, which is hydrophilic. So apolipoproteins are can be classified into the two, the periphery and the integral. So integral, these are the periphery apolipoproteins, and these are the integral apolipoproteins. So periphery apolipoprotein are the C1, C2, C3, E, and integral apolipoproteins are B48, B100, and A1. So, on the basis of the density and the electropoietic mobility, lipoproteins are further classified into the following classes. These are the chylomicrons, the very low density lipoprotein, and the low density lipoprotein, intermediate density lipoprotein, and the high density lipoprotein, and the free fatty acids. So as we can see, this is a ultra centrifugation of the lipoproteins. So more the protein content in the lipoprotein, the more the sedimentation will occur, more they will appear in the bottom of the test tube. But this is electrophotic, so more the protein content, the more they will move towards the anode. So now my friend Abhinav will continue after this. Thank you.
Good afternoon, everyone. I will continue from here. Chylomicrons. Synthesis of chylomicrons. Chylomicrons are synthesized in the intestinal mucosal cells and they are secreted into the lacteals of lymphatic systems. They are rich in triglycerides, and when the chylomicrons are synthesized by the intestinal mucosal cell, they contain only ApoB48, while ApoC2 and ApoE are added from HDL in blood during transport from intestine to other tissues. Now, the metabolism of chylomicrons. The main site of metabolism of chylomicrons are adipose tissue and skeletal muscles. The half-life of chylomicron in blood is about 1 hour. The enzyme lipoprotein lipase located at the endothelial layer of capillaries of adipose tissue, muscles and heart, but not in liver. The ApoC2 present in the chylomicrons activates the enzyme lipoprotein lipase. The lipoprotein lipase enzyme hydrolyzes the triglycerides present in chylomicrons into fatty acids and glycerols. Muscles or adipose tissue cells takes up the liberated fatty acids as the triglycerols of chylomicrons are degraded. They lose the ApoC2, which is returned to HDL. Liver takes up chylomicron remnants. As the triacylglycerol content is progressively decreased, the chylomicron shrink in size. These remnants containing dietary cholesterol, ApoB48, ApoE are taken up by the hepatic cells by receptor-mediated endocytosis. The ApoE binds to the hepatic receptors. The function of chylomicrons. Chylomicrons are the transport form of dietary triglycerides from intestine to the adipose tissue for storage and to muscles and heart for their energy needs. Thank you.
Good afternoon, everyone. I will continue from here. So, the synthesis of VLDL. VLDL is synthesis in the liver and it contains endogenously synthesis from the triacylglycerol, hepatic cholesterol, ApoB100, ApoC2, and ApoE. The ApoB100 is the major lipoprotein present in VLDL, while the ApoC2 and ApoE is obtained from HDL. Now, the metabolism of VLDL. The half-life of VLDL in the serum is only about 1 to 3 hours. When they reach to the peripheral tissue, the ApoC2 activates the LPL, which catabolizes triacylglycerol and lipids fatty acids that are taken up by the adipose tissue and muscle. Now, the remnant is designated as IDL, that is intermediate density lipoprotein, and contains the less of triacylglycerol and more of cholesterol. The major fraction of IDL further loses triglyceride by the action of hepatic triglyceride lipase so as to be converted into LDL. This conversion of VLDL to IDL and then to LDL is known as the lipoprotein cascade pathway. Now, the function of VLDL. The VLDL carries triglycerides or triglycerols from the peripheral tissue, from the liver to the peripheral tissue for the energy intake.
Good afternoon, sir. Good afternoon, everyone. So, two. I will continue from here. The next topic is low density lipoproteins. Low density lipoproteins are mainly synthesized from plasma VLDL, and it carries the main lipoprotein present in LDL is ApoB100, and most of the LDL particles are derived from plasma VLDL, as I said earlier. The half-life of LDL is about 2 days. Metabolism of LDN and LDL receptor. Low density lipoproteins are taken by peripheral tissues, and LDL receptors are present on all cell but mainly abundant on hepatic cells. The receptors are present on pits, that is called Cathelian pits, and binding of LDL to the receptor is by ApoB100. So the uptake of cholesterol from LDL is a highly regulated process. And when the ApoB100 binds to the ApoB100 receptor, the receptor LDL complex is internalized by the endosome vesicle, thus formed fuses with lysosome. And as we can see here in the diagram, the LDL B100 LDL receptor, which binds with the LDL B100 lipoprotein, comes inside the tissue cell, and then the lysosome acts on it, digests the cholesterol, and the TAG thus which came in the tissue are digested and formed glycerol and fatty acid. The fatty acid is used up by the peripheral tissues. The free receptor can now return to the membrane surface to bind further LDL molecules, as you can see in the picture. Approximately 70% of LDL is degraded in the liver, and the rest are degraded in the extrahepatic tissues. Function of LDL. The main functions of LDL is to transport cholesterol from liver to the tissues, and uptake of cholesterol from LDL by the cells increase the cellular level of cholesterol in the peripheral tissues, and it also has a modular effect on the synthesis of LDL receptor. LDL also serves to transport fat-soluble vitamins, lipophilic xenobiotics, and bacterial endotoxins. The cholesterol, thus, which is liberated in the peripheral tissues, has mainly 3 functions. The first one is synthesis of steroid-like steroid hormones. Cholesterol may be incorporated into the membranes As we know, the plasma membrane contains cholesterol, and cholesterol may be esterified by to a monounsaturated fatty acid by ACAT, acetyl coenzyme cholesterol acyl transferase for storage.
Good afternoon, everyone. I'll be discussing about HDL metabolism. At first, as a basic structure of the all lipoproteins, in the inner core of the HDL, it is cholesterol ester and diacylglycerol, and in the peripheral part has ApoA as a main apoprotein and ApoC and ApoE2. Then in the metabolism part, we'll discuss about with respect to 4 points: synthesis of HDL, maturation, then synthesis of HDL2 and uptake by the liver. Synthesis. HDL is synthesized. HDL can be synthesized by both liver and the intestine, and it is synthesized as nascent HDL. It is discoid in shape. Then in the maturation part, from the peripheral tissues, the cholesterol comes by the scavenger receptors and by the ABC receptors. This cholesterol comes in the HDL, and by the ApoA1, which is present in the HDL, it activates the LCAT enzyme, which converts the cholesterol to cholesterol ester. And then this cholesterol ester go in the center core of the HDL. These are the receptors, and now when this cholesterol go in the core of the HDL, it is maturated into the HDL3 or spherical HDL. This spherical HDL, after formation, is uptaken by the liver cells by the scavenger receptors. Whenever this HDL is present in the plasma, then this HDL3 is converted to HDL2 by the protein CETP, which transfers the cholesterol ester from the HDL3 to the VLDL and IDL, and in exchange of it, from this VLDL and IDL, TAG comes to the HDL, and this HDL3 is converted to HDL2, and this HDL2 is then after is uptaken by the liver.
ये LDL কোথায় ট্রান্সপোর্ট করছে কোলেস্টেরল কোথায় কোথায় করছে
From liver to the peripheral tissues.
from liver to
Peripheral tissues.
but LDL is synthesizing the circulation, it's not carrying the fat from the liver. VLDL is a lipoprotein which is synthesized in the liver, so it carries from the liver.
Sir,
You are not accusing VLDL for carrying the fat from liver, but you are accusing LDL for carrying the fat from liver.
VLDL carry fat from liver, then VLDL it changes into IDL, which is intermediate density lipoprotein.
Then LDL.
Then IDL changes into LDL.
LDL, fine. So where comes the LDL, function of LDL to transport fat from liver?
So that remnant triacylglyceride of VLDL, which comes into LDL, sir, which initially came from liver.
What are the receptors which are responsible for uptake of LDL in the liver?
Apoprotein E.
ঠিক আছে, তিনটে আছে, একটা হচ্ছে স্ক্যাভেঞ্জার রিসেপ্টর, স্ক্যাভেঞ্জার পাথওয়ে,
Sir,
scavenger pathway. There are 3 pathways: scavenger pathway, apo-immediate pathway, apo-100 pathway. So my question was phosphatidylcholine. Phosphatidylcholine, why it is important? Should we have more phosphatidylcholine in our diet or no? Suppose you have LDL more, should you prescribe the diet or advise a diet to take more phosphatidylcholine? If yes, then why?
If there is deficiency of phosphatidylcholine, there can be respiratory diseases as
They can be.
respiratory. They act as surfactant in respiratory system.
There can be.
Surfactant as respiratory system. So
সামনে সামনে আয়, সামনে বুঝতে পারছি না কথাটা। বাবা একটু জোরে বল, আর নাহলে বলিস না।
রেসপিরেটরি সিস্টেমে সারফেন্টেড হিসাবে কাজ করে।
Surfactant. What is the lyso? What is lysolecithine? What is the difference between lysolecithine and lecithine? What do you mean by lipotropic factor? Okay. Good.
Good afternoon, everyone. So I'm going to. Thanks. So we are going to present. So we are going to represent our presentation on the topic of normal regulation of blood glucose.
I just want to see who are talking. We will get the second group. This is remaining. I'll make sure you will repeat it. What?
So we are going to present our presentation on regulation of blood glucose. So our first page is normal blood glucose level. Normal blood glucose level in fasting period is 70 to 100 mg per dl, and in postprandial level is its postprandial is up to 140 mg per dl. It can be regulated by various physiological limits. Rate of glucose entrance into the blood circulation and the rate of its removal from the blood circulation. So if it's below 70 mg per dl, it's called hypoglycemia. If it's above 140 mg per dl, it's called hyperglycemia. If it goes above 180 mg per dl, it's called renal threshold, in which kidney can't reabsorb glucose. So our next topic is rate of glucose entrance in the blood. Why? It can be absorbed by the intestine, by the breakdown of carbohydrates, by various enzymes, and it can be in hepatic glyconeogenesis. Glucose obtained from other carbohydrate, also example fructose and galactose. Rate of removal of glucose from the bloods depends on oxidation of glucose by tissue to supply energy to our various organs such as brain, hepatic glycogenesis, glycogen formation in muscles, conversion of glucose to fat in adipose tissues, formation of fructose in seminal fluids, lactose in mammary gland, formation of ribose sugar and nucleic acid synthesis. So my portion is finished here.
Good afternoon, everyone. I will continue with hormonal control system. Hormone play a significant role in blood glucose regulation. The hormones which elevates the blood glucose are called hyperglycemic hormones, such as glucagon, epinephrine, growth hormone, ACTH, cortisol, and thyroid hormones. And the hormones which lower the blood glucose level are called hypoglycemic hormones, called insulin and incretins. So we are starting with insulin. After a meal, the blood glucose level rises in the blood as it cannot readily enter into the cell. This causes the beta cells of the pancreas to release insulin, which is a polypeptide hormone. The insulin acts as a hypoglycemic hormone and lowers the blood glucose level by promoting its uptake, utilization, and storage. It stimulates glycolysis glycogenesis and inhibits gluconeogenesis and glycogenolysis, and thus it reduces the blood glucose level. Moving on to incretins. Incretins are metabolic gut hormones which are released in the blood after a meal. It stimulates glucose dependent insulin secretion, suppresses glucagon release, delays gastric emptying, and promotes satiety. And hence, it reduces the blood glucose after a meal. Thank you.
Glucagon is a polypeptide hormone. It increases the blood glucose level. It is called hyperglycemic hormone as its main function is increases the blood glucose level. When in fasting stage, glucagon is releases from the alpha cells. Then through blood it went to liver and bind with specific receptor cells and activate GS protein. Then GS protein activates adenylate cyclase. Adenylate cyclase then convert ATP to cyclic AMP. Cyclic AMP then activates protein kinase A. Protein kinase A phosphorylates several enzymes. As a result, glycogenolysis happens in which glycogen breakdown into glucose. Then in glycogenesis process is decreases, in which glycogen synthesis is inhibits. In gluconeogenesis process it is increases. In this process, non-carbohydrate substances like lactate, glycerol and amino acids converts into glucose and in blood glucose level is increases. In these all processes, glucagon elevates the glucose level in blood and it prevents hypoglycemia and maintain overall
corticoid receptor and then act as a altered gene transcription. And epinephrine is also called as catecholamine and it released from adrenal medulla. Then it binds with adrenergic receptor like beta 2 in liver, beta 1 in heart and alpha in tissue. Then it activates the adenylate cyclase and increase cyclic AMP and activate also phosphorylase kinase. All those processes it increase the blood glucose level. And growth hormone it also it secrete from anterior pituitary gland. Then it binds with growth hormone receptor and activates STAT pathway and alters gene transcription. Clinical significance: hyperglycemia. It means increase the blood glucose level in blood. Diabetes mellitus. Usually diabetes mellitus are two types: diabetes mellitus 1 and diabetes mellitus 2. Diabetes mellitus 1 is occurs due to destruction of beta cells in pancreas, and diabetes mellitus 2 is most common diabetes in human body. 95% of diabetes in our body is diabetes mellitus 2. It is occurs due to insulin resistance. Then hyperadrenalism, overgrowth of adrenal gland secretes adrenaline and cortisol hormone which also helps to increase the blood glucose level. Hyperpituitarism, over secretion of GH hormone degrade fat into fatty acid. Free fatty acid impair the insulin secretion and also increase the glucose secretion. Hyperthyroidism, in hyperthyroidism liver stimulate more to secrete the glucose via gluconeogenesis and glycogenolysis. Hypoglycemia, decreased blood sugar in the blood. It is occurred due to improper dose of insulin and insulinoma. Insulinoma means the benign tumor of pancreas which stimulates or lead to uncontrolled secretion of insulin. So hypoglycemic condition occurs. Hypoadrenalism, it also decrease the blood glucose. It also decrease the uptake of blood glucose level. And hypopituitarism, normally growth hormone prevent the blood glucose balance to drop too much low. But in the case of hypopituitarism, growth hormone cannot perform this system, and hyperglycemic condition is occurred. And hypothyroidism, in hypothyroidism, body cannot trigger more amount of glucose in the blood, so hypoglycemic condition occurs. Thank you.
A very good catch question. Explain why. What are the why you do not describe everything about this thing? What is the reason? This is one important aspect I want to highlight. What possible like that?
Hypoglycemic hormone.
But no, which are the three periods? The largest endocrine gland of the body. It is the largest endocrine gland of the body. Incretins. In money. The largest endocrine gland. It has to be civil tax. Yeah, yes. And many of the facts were done to so like a widely after the discovery of this Incretins are highly important in maintenance of diabetes. Now, the major problem in your presentation is you have mentioned different hormones, right, for maintaining blood glucose, but you have not mentioned different metabolic state, how those hormones act in those metabolic states. Do you have any idea about different metabolic states? Actually, talking about regulation of blood glucose. In one line, you have said that the answer but we have not mentioned how those hormones behave. Yes, that is the metabolic state. That is the most important thing. That is what is. So, what are the different metabolic states?
Sir, glycolysis ওগুলো বলতে পারছেন?
হ্যাঁ জোরে বলো জোরে বলো না খালি বলো আমার মতো বলো জোরে মাইক তো বলছো যে কিছু বুঝতে আছে First, figure one question. Just go back to the first slide. First question. First line. Abduction from intestine. What does it mean? I ask you very difficult question. Carbohydrate traits. Carbohydrate traits. Carbohydrate. See, you have taken meat and another. I have taken butter. You have another. It will come. Carbohydrate rich food or predominantly carbohydrate. Okay? Or carbohydrate only. Carbohydrate rich food, carbohydrate from our basic source of glucose in blood from intestine is carbohydrate. That comes from basically and okay, we get both good and right how does it and then any drug which block the absorption of carbohydrate from the intestine. See, when this question comes, this is very difficult question to answer. When teaching this item, I got this one, probably through this year. So I must have mentioned that in two ways you can answer this question. Either you go by hormone and their function, or you go by metabolic state and the role of the hormones in your metabolic states. Either these two ways, but in both the cases you have must mention the name of the hormones and the metabolic state. Because the metabolic state is important, which dictates which hormone will be secreted. Then comes the function of hormones. If the hormones are not triggered for secretion, then how the hormones react? When you are suffering from hypoglycemia, so what are the conditions when you suffer from hypoglycemia? And when these glucagon like peptides or glucagon will be secreted, that we must mention. And in that condition, when these are secreted, see there are certain local hormones like Incretins, which were behind the veil for many decades. Now we know many of the diabetes is not due to hypersecretion of insulin, but the hypersecretion of other hyperglycemic hormones. So those things are being addressed nowadays in the advanced treatment of diabetes. Number one. Number two, you must mention that insulin, hyperactivity of insulin is not only due to hyposecretion of insulin, but also increased resistance of insulin. Without mentioning that insulin resistance is not the cause for pseudo hyperinsulinemia. Means what? This insulin level is high in the blood, but you know that pseudo hyperinsulinemia, but when you measure insulin, you find insulin is very high in that patient. Then dilemma. How come he is suffering from diabetes? Because insulin is secreted more because of insulin resistance. Correct? And whenever this insulin resistance comes, then the fourth condition comes. But three conditions are very condition: fasting, starvation, and fourth one, pathological condition, diabetes mellitus. In diabetes mellitus, there are two types: type 1, type 2. Don't go for detailing, but just mentioning one minor. And then go for Incretins. Mention Incretins and their function in one minor. And then the drugs, hypoglycemic drugs. Number one, oral hypoglycemic drugs, Phytonuries. You must mention, oral hypoglycemic drugs. Then metformin. What is the function of metformin? Reduces inducing level of glucose. Then the Phytonuries. So these questions we ask.
Nothing can be more simple than the first layer. You understand?
These are very important topics. Anyway, you tried well. You have attended from one election, but overall election was we can cover the whole topic.
It's a last topic.
Last topic.
It's a last topic.
So anyway,
It's for 1 hour class.
next, quickly.
A very good evening to all of the people present here, both my classmates as well as my professors who are present here. Myself, Ankun Chakraborty, and these are my teammates. A very good evening to all the people present here. Myself, Ankun Chakraborty. Also, very good evening to my professors present here. And my teammates are all present here. Myself, Ankun Chakraborty. Herself, Amrita Chakraborty, Anas Sahai, Ankun Bera, and lastly but not the least, Aniket Hajra. Today we are presenting a presentation on the topic of inhibitors based of translation, and we'll start from our first candidate.
Good afternoon, everyone. Today, our topic of discussion is translation inhibition. As we all know, translation is the process where mRNA gets converted to protein, and this protein is an essential component of cell. So, any inhibition in translation process can directly affect cell regulation. Now, the point is why translation inhibition is important in biochemistry, because many antibiotics, toxins, and other regulatory substances can directly affect the translation process at any stage, and by understanding the mechanism, we can use it for human welfare. So, as we can see, translation is a complex process and it has become a favorite target for inhibition by antibiotics. Majority of antibiotics interfere with the bacterial protein synthesis and are harmless to higher organisms. As we are eukaryotic organisms, we are basically concerned with prokaryotic organisms like bacteria, mycoplasma, PPLO, and its harmful effect on human. And few important antibiotics on translation is described next. Now, on the basis of target, there are types of inhibitors of translation, such as inhibitors of prokaryotic translation, number 1, number 2, inhibitors of eukaryotic translation, and number 3, inhibition of both the prokaryotic and eukaryotic translation.
Inhibitor of prokaryotic translation. First inhibitor of prokaryotic translation is tetracycline. Tetracycline's target 30S subunit of 70S ribosome. It inhibits the binding of amino acyl tRNA to the A site of ribosome complex. Tetracycline can also block eukaryotic protein synthesis. However, it does not happen because of eukaryotic cell membrane is not permeable to this drug. The first picture is of prokaryotic 70S complex, and the second is of tetracycline capsule, which is an antibiotic capsule which is used to treat viral infection.
Good afternoon, everyone. I will continue from chloramphenicol. Chloramphenicol target the 50th subunit of the 70th prokaryotic ribosome. Here the methyl group attached with the amino acyl tRNA to form peptide bond by the enzyme peptidyl transferase enzyme. Chloramphenicol inhibit the peptidyl transferase enzyme, so the peptide bond is not formed and the elongation is terminated. Next is erythromycin. Erythromycin is also target the 50th subunit of the 70th prokaryotic ribosome. It inhibits the ribosome translocation. So
EF factor, EF stands for
interfering with the EFG factor.
EF stands for what? EF stands for
elongation factor. And there the ribosome cannot be moved by the one codon length. So elongation is stopped. And next is streptomycin. Streptomycin is target the 30th subunit of the 70th prokaryotic ribosome. It causes misreading of mRNA, so the initiation is terminated.
Here is the erythromycin and streptomycin, and I am continuing from here. And so the next point is inhibitors of eukaryotic translation. The inhibitors of eukaryotic translation, first of all, we see cycloheximide. Its target is 60S subunit of 80S ribosome, and it blocks the peptidyl transferase activity. If peptidyl transferase activity is inhibited, so the peptide bond is not formed, because the peptidyl transferase help in peptide bond formation. So if peptide bond not formation, protein not formation, therefore the translation is inhibited. And next to the Ricin. This target is 60S ribosomal subunit of 80S ribosome, and its mechanism is block the elongation process in translation. And it is very highly toxic molecule, mainly found in castor seeds. So oil produced from the castor seed contain this highly toxic molecule Ricin, and India is one of the most highest producer of castor oil, And this castor oil is used in beauty products, self-caring products, groceries. So it is very harmful. So it is the castor oil containing highly toxic molecule ricin. And next, coming to the diphtheria toxin. This diphtheria toxin is inhibited this translocation. Here we see the translocation. Mainly the translocation is the this tRNA from A site coming to the this P site, and this if this is blocked, then this side is not empty. If this side is not empty, then new tRNA containing the amino acid with respect to the codon not bind here, so further the protein synthesis inhibited. And this diphtheria toxin mainly inhibit the mammalian protein synthesis, but some mammals like mice are resistant to diphtheria toxin, and because the diphtheria toxin does not cross the cell membrane of this mice cell, so it is not effective to this mice. Some drugs which inhibit both prokaryotic and eukaryotic translation, as example puromycin. This puromycin, it is a structural analog of amino acid tRNA. If it is a structural analog of amino acid tRNA, means the structural similarity to the amino acid tRNA, it interfere with this A site. So this A site interfere with this A site and inhibit the translation process, because this site is not empty further. And this is the clinical importance of inhibitors of translation.
There should be always a purpose of each and every presentation. And to really describe what is the purpose of this actual presentation is to find out what sort of a help it can do to the mankind. So presenting to you guys the clinical importance of inhibitors of translation. What we are talking about here is different aspects of how inhibitors of translation can usually benefit us in terms of both physique as well as daily life activity. For an instance, the first one talks about antibiotics. So we all know what antibiotics are. They prevent diseases from happening, or if the disease has already occurred, it helps us to reduce it. Talking about antibiotics, we have got, first of all, we'll be talking about some antibiotics which are only effective for prokaryotics. Some of them are tetracycline, then we have doxycycline, then also we have chloramphenicol, we have erythromycin, we have streptomycin, we have neomycin, gentamicin. Now, these all might just sound like drug name to you all, but what are the actual purpose of it? Let's say for an example, tetracycline. If you look at tetracycline basically serves the purpose of preventing the contamination of atypical pneumonia, as well as for an example, chloramphenicol. It prevents meningitis as well as typhoid. Coming to gentamicin and streptomycin, these all prevent gram-negative bacteria infections like plague, cholera, and these are all for prokaryotes. But if we jump into the eukaryotic mechanism, well, prokaryotes actually cause the problem after translation. But in the case of eukaryotes, what happens is that eukaryotes actually stop the translation in the human body so that problems can be caused. For example, if we jump into the eukaryotic part, we have got diphtheria toxin. What happens in diphtheria toxin is that the bacteria, Corynebacterium diphtheria, actually stops the eukaryotic elongation factor 2, affects it, and then stops it, which causes the stoppage of translocation of the ribosome, which indirectly causes the termination of elongation, which causes acute protein deficiency, as because protein synthesis is completely stopped in the human cell. Coming to ricin, which is found in castor beans, these also do the same thing, but they attack the 28S subunit of the RNA, like the greater subunit of the RNA, and take out the adenine molecule, which again does the same thing, stops protein synthesis. When we come into the last part, which is cyclohexamide, cyclohexamide just defeats the purpose of translocation of 60S subunit of ribosome, which again causes protein deficiency in the human cells. Now, these are all for human purposes, but as my fellow teammate Ankun Bera said, that there is something called puromycin. Puromycin is not actually used for human purpose. It is actually for lab, proceedings, where we study different sorts of genetic performances about how things are actually performing, and we use that to stop them. So these are for antibiotics, or you can say inhibitors of translation for human use. And puromycin, when it is considered, it is only used for lab use. It is not for human use. So that brings us to the end of our presentation today. Again, we'll be acknowledging all our teammates here. This is like, yes sir. I would come both to the autoimmune disease and cancer therapy. I'm very sorry I skipped that. But coming to the autoimmune part, the mTOR which is written there, that is mammalian target of rapamycin, which what basically does is that the mammalian target of rapamycin actually causes the, because it is associated with rheumatoid arthritis, which is an autoimmune disease. So to prevent it, we attack the mTOR pathway, which indirectly causes the lessening or less proliferation of the T cells, which also cause inflammation, causing cytokines to decrease in number, and also increase the activity of regulatory T cells, which causes the rheumatoid arthritis, which is our own immune system causing problem to us. It suppresses it. Yes? Yes, B cells. Yes, sir. And yes, cancer therapy, basically we all know that cancer is basically nothing but a lump of cells which is proliferating uncontrollably. The controlling mechanism has completely defeated. What happens in cancer therapy is that if we stop the inhibition or translation, if we inhibit the translation, what happens is that the growth promoting proteins, which is like, let's say cyclin and all those, they get stopped producing. So when growth promoting proteins get stopped, the cell cycle shuts down, and when the cell cycle shuts down, the cancer stops growing, which causes sometimes apoptosis, or sometimes it becomes more provocative to radiotherapy, which causes the death of cancer in the further times if chemotherapy is applied. Sir, last time ঠিক করে articulate করতে পারলাম না।
So see the last part, the cancer therapy application, this has been a hotspot for asking question in last 2 years for the university. Last year's 2 questions came on this. And last year also came one question. So this is very important that antibiotics can be used as cancer therapy. Right?
Yes.
Or translation of inhibitors. These translation inhibitor, they all inhibit the normal process of cell proliferation. So they can be used as a
Cancer inhibiting substance. Thank you so much, sir. Sir, I'm very sorry, but I don't know the mechanism of mTOR.
Premature release of the polypeptide, actually, it should be said.
Base analog. No, base analog. এটা বলো দেখি কি হবে? ADP রাইবোসিলেশন মানে কি? আগেরটা যাও।
আপনি জিজ্ঞেস করছিলেন রাইসিন থেকে কিভাবে